Advancements in imaging have also helped us a lot. Dr. Spector and I, when we do these surgeries, we often are sitting before surgery and looking at the imaging for a few minutes. We want to know where the pituitary gland is relative to the tumor because we want to preserve the pituitary gland. We want to know where the pituitary stalk is. We want to know where the optic nerve is. And with advancements in imaging, we can now see that stuff pretty good, and it allows us to create a good plan. It also allows us to know whether or not we can do the surgery through the nose. Sometimes there are barriers that would prevent us from being able to get to a tumor. Here's a perfect example of where the imaging was invaluable. This person had what's called a Vidian canal schwannoma. It's a very rare tumor at the base of their skull. And they came to us to see if we could remove this through their nose. They had actually been over to Tampa where they talked about this big surgery where they were going to make an incision around the ear. They were going to lose hearing. Surgery was going to take about 15 hours. They were going to be in the hospital for a week, and they didn't really care for that. So they came to see us, and the imaging allowed us to determine whether or not we could get to it. And the key thing to know about this tumor is right here, on this side is the internal carotid artery. Well, if the tumor is behind that artery, and I try to go through the nose, the artery is going to be in our way, and we're not going to be able to reach the tumor. But because of the imaging, we can actually see that the tumor is actually displaced the artery posteriorly, saying that if we go through the nose, we're going to find the tumor first, we're going to dissect the tumor, and at the very end is where the artery is going to be. And so this is an approach that we can get to the tumor without having to worry about the blood vessels much. And so in this patient, we did go endoscopically. She did fine, and actually has had no problems since her surgery. The other thing that's very helpful for us is having an interventional neuroradiologist. And that's someone who gets me out of trouble if we were to injure a blood vessel. If you were to injure the carotid artery when you do these surgeries, patients can die on the table. They could have a massive stroke. Now, fortunately, it's very, very rare. We have had one patient in the past 7 years that happened to. That patient had a craniopharyngioma, and it was a very difficult tumor. But because we have interventional radiology, we're able to stop the bleeding, take the patient to angio. Our interventional radiologist was able to occlude the vessel, and the patient was perfectly normal. So being able to have good ancillary staff to be able to help get you out of a jam is also integral for these kind of surgeries. We also have patients who have had surgery all over the country who have residual tumors, and the reason their tumors are remaining is because they're stuck to a carotid artery. And the only way to cure them of their disease is to remove the carotid artery. And so one of the other things that we'll sometimes do is what's called a balloon test occlusion. Before surgery, we'll have an interventional radiologist actually put a balloon in the carotid artery, occlude it, and see how the patient does. If they don't have a stroke or they don't have stroke symptoms, they leave the balloon there, and then we can go and do the surgery, and we actually can ligate the carotid artery to remove the tumor and know they're not going to have a stroke. If, when they put the balloon up, they start to have symptoms, they take the balloon down, the patient is fine, but we know that there's no way we're going to be able to remove that tumor because we can't remove the blood vessel. So that's something else that we use. Fortunately, it's fairly infrequent, but we have used it from time to time in the past years, and to be able to do endoscopic skull-based surgery, it's a necessity. This is a perfect example of a case where you'd want that information. Here we have a tumor, and the carotid artery is going right through the middle of it. I know there's no way we can remove that tumor without having to sacrifice that carotid artery. So that information up front lets me know how aggressive I can be with this and whether I can tell the patient we might be able to cure them of the disease. Neuronavigation we talked about a little bit earlier, but that is also essential. Basically, it's a computer-based system whereby the patient undergoes an MRI in the morning of surgery or CT. Those images are transferred to a computer station. And on that computer station, they put those images. That creates a three-dimensional image of the brain. What I then do, once the patient is asleep, we do what's called a registration. And this right here is the stealth system. We now are using the Stryker system. But I'm telling the computer where there are certain points on the patient's skin and correlating it to the scan. And then from that, it's able to regenerate things and basically create a GPS to the brain. So that while I'm doing surgery, I can then use that probe in the nose, and it'll tell me exactly where I am on the MRI. So these are the things that we call lifesavers. This is what's put on the patient's head. They're just little stickers. They're called fiducials. They allow us to kind of create this three-dimensional image and make the accuracy of these systems about 1 or 2 millimeters. So the accuracy when we're in there is about 1 or 2 millimeters, very precise, which is what you need when you're operating around the carotid artery. More recently, with the newer system, actually, when we use that technology, this is an example of what we get. So here we are. This is during the surgery. We actually have the probe in the nose. And, you know, Brian and I know what we're looking at here, but for the most part, all it looks like is a big field of blood. Okay? and you're trying to say to yourself, okay, is that a little bit of tumor there, or is that the optic nerve? What exactly am I looking at? I put the probe in there, and the probe tells me exactly where I am. That's actually the bottom of the optic nerve right there. So if I want to biopsy that or remove that, I just hurt that patient's vision. Okay? So this image guidance is very valuable to us. It lets us know when we need to stop, and it helps us confirm, is this really what we think we're looking at? The most common thing that we wonder about lots of times are blood vessels. If we get in there and we see something that looks like a blood vessel, we're not quite sure. Is this the carotid artery, or is this just a large vessel feeding the tumor? This is the newer version. This is the Stryker version, so we don't have to put those little fiducials on there. The patient doesn't have to have anything put on their head, except at the time of surgery, they go in the room, we put this mask on, we basically push a button on the system, it registers everything, and we take this off. So it works pretty good for us. You can also do the traditional registration with the fiducials. But this is kind of the future for a lot of these companies. They're trying to make it so that you don't have to put stickers on people's heads and make the systems more accurate. This is why it's valuable. So here's a case where we're doing a tumor, we're in the middle of the tumor, and we see a blood vessel, and we're like, what vessel is that? We're not quite sure. All we see is tumor everywhere. We put the probe in there and realize that's the carotid artery that's in the middle of that tumor. We got to stop there. Okay, I can't keep going. I can't damage that. That's very valuable information. It could have easily been a blood vessel from the tumor as well, which we would then sacrifice. So the image guidance is very good for that. It's very good to know when you're done. So when we say we think this is the end of the tumor, we think this is the back wall, we can put the probe in there. It shows that you're at the very back of the tumor. We don't need to go anymore. We've actually removed everything that we think we've removed. And then, to me, the best purpose to have this stuff is for the pathologist. So that when you take a biopsy, you take a specimen, you give it to the pathologist, and he goes, now where exactly did you take that? You can actually take a snapshot and show him exactly where the specimen was taken to prove that this is the area of interest. All right, so we've already kind of gone to what the benefit of the endoscope is over using a microscope. This is a cadaver model where on the left they're using a microscopic view where you can see the cellar, the base of the brain, and this is the clivus. This is the exact same view using an endoscope on the right side. You have a wider field of view. You can actually see where the carotids are on either side, and you can see above and below the area of interest. Giving you a bigger field of view is more likely to allow you to then see more anatomy and more structures. So again, the analogy is going from this to this, giving you a bigger field of view. This is the same thing with a cadaver model where we're superimposing the two images. This is what you get with a regular transsphenoidal approach, and then the bigger circle is what you're getting with the endoscope. The other benefit of using an endoscope is that once it's in there in the nose, it doesn't have to stay in that position. Once you start to remove the tumor, you can actually advance the endoscope into the tumor. You can advance it above the tumor. You can take the endoscope and have it look to the left. You can have it look to the right, have it look up, have it look down. And so you're likely to find small remnants of tumor that you might otherwise not find if you just have a fixed camera, such as a microscope, during the surgery. This is a case where we removed a tumor. The tumor was eroding through the base of the brain, called the diaphragma, up into what we call the suprasellar cistern. And we thought that we had pulled out all of the tumor. We thought that we had it all out, but we weren't quite sure. And so what we then did is we advanced the endoscope. So we now are looking in. This is where tumor used to be, where the endoscope is now. And we're actually looking up into the brain. We then look further, and this is actually the optic nerve that we're seeing with the endoscope. And you can clearly see we don't have any tumor on it. And this little guy right here, that's the pituitary stalk. So we also see there's no tumor left on the pituitary stalk. This is something that we just can't see with other technologies. It makes the endoscope superior for our purposes.